Welcome to our PrecisCa tumor board on myeloma. I'm Dan Pollier from the University of Colorado. I'm very excited to be with you today for some really interesting cases. I'd like to have our esteemed panelists introduce themselves, and just maybe starting from left to right, perhaps Dr. Nuka can begin.
Thank you for having me. I'm Ajay Nuka. I'm an associate professor at the Winship Cancer Institute. I am the director of the myeloma program, and I'm the medical director for the Winship Research Informatics Shared Resource.
Hi, I'm Peter Forsberg, also from University of Colorado, an assistant professor out here in the myeloma group with a specialty in myeloma and plasma cell disorders.
Thank you for having me. I'm David Schuster, and I am the director of the Division of Nuclear Medicine and Molecular Imaging at Emory University.
So this is a 70-year-old male with IgG lambda multiple myeloma and an 11-14 translocation who previously received induction, followed by autologous stem cell transplant, and then daratumumab, pomalidomide, and dexamethasone, now with a slow progression of his disease. And we're going to talk about what that means. But the bottom line question is, what is the optimal treatment for relapsed refractory 11-14 translocated multiple myeloma? So this patient initially presented with symptoms of dyspnea and lightheadedness, was found to be severely anemic with a hemoglobin of 5. Performance status was 1. Medical history of just hypertension and no real contributory social or family history. And a bone marrow biopsy showed 90% lambda light chain restricted plasma cells with the 11-14 translocation. We're going to go over his imaging in a moment, but the patient was treated with cyclophosphamide, orkezimib, dexamethasone, and this was complicated by anemia. So let's go ahead and look at the imaging with Dr. Schuster.
Yeah, so the first thing I'd like to say is whoever picked this up on plain film, I'd like to shake their hands. So I think we're seeing here just some subtle erosion of one of the posterior ribs, and what looks like a widening or enlargement of the costovertebral space. So that's probably the paraspinal mass causing, some local structures to be pushed apart. Of course, you can see this better on a CT or FDG PET, but this was seen on plain film. So
great, thank you. Yeah, pretty subtle. But and just going back, we're told that there's a destructive mass. Mm-hmm. And a paraspinal mass extending into the pleural space as well. So, and this patient was treated with cyclophosphamide, orkezimib, dexamethasone. And then we were told this was complicated by anemia, and then had some palliative radiotherapy to the T9 and L5 lesions. So the patient then switched treatment to lenalidomide, orkezimib, and dexamethasone, and obtained a very good partial response and underwent the autologous stem cell transplant that we heard about with high-dose melphalan. No maintenance therapy, and 6 months later developed disease progression and started daratumumab, pomalidomide, and dexamethasone. This continues. There's a gradual increase in the monoclonal protein from undetectable to 1.4 grams per deciliter on the latest specimen. So Dr. Nuka, maybe you could start off, and if we could backtrack a bit, who are patients these days who do not receive maintenance therapy after an autologous stem cell?
Sure. So there are more than several. I would say there are at least 6 randomized trials across all continents showing the benefit of maintenance versus no maintenance in this scenario. So the typical maintenance post-transplant unmaintained would give us a PFS benefit of close to 3 to 4 years. And that exact number is doubled with the maintenance. So that is expectation nowadays for somebody who's standard risk. And this patient is considered standard risk based on the presence of translocation 11-14, does not exhibit any high risk features. So yet we don't see that kind of a benefit even unmaintained 6 months after progressing 6 months after transplant is not the expectation, but unfortunately happened in this patient. So now one additional advantage for somebody like this who has translocation 11-14, one of the lymphoma drugs, venetoclax, really has a role and certainly can be used in a combination. So it has been shown to be very well combined with delivering synergy with the proteasome inhibitors, with bortezomib, with carfilzomib, even with daratumumab and bortezomib with venetoclax. There's a recent trial that had shown significantly improved PFS. So if this is a patient that would be eligible for a trial, I would proceed with a trial which has venetoclax available as a part of the therapy. The patient is not eligible. My preferred option for this patient would be carfilzomib plus venetoclax off-label, and we've been really successful in bringing these, in obtaining venetoclax for the patients with translocation 11-14. One criteria, there was one trial that was a phase 3 trial that included all patients, including the non-translocation 11 patients, called the Bellini trial, which resulted in patients who do not have translocation 11-14 to have increased mortality, and the trial was stopped. Now all the future trials are geared towards only patients who have the biomarker of translocation 11-14. So that would be my choice.
Thank you. And Dr. Forsberg, would you think that this level of increased monoclonal protein would warrant a change in the maintenance strategy?
So, I think, in terms of the threshold at which to initiate new treatment for, progressive disease, there are some at times, sort of subtleties in terms of that, but we do have uniform criteria that define progression of disease, and so, that includes a rise in monoclonal protein by 0.5 grams per deciliter, or 25% in patients who don't have quite the same, reduction threshold. But essentially, a rise from undetectable to 1.4 grams per deciliter would certainly fall in the realm of the type of biochemical progression of disease. Progression of disease evaluated and sort of defined by changes in monoclonal protein or light chain level that would prompt a change in disease. So I do think that this scenario with a patient who, even if it's slowly rising, if you reach a threshold in this realm, usually we use biochemical progression to prompt a change in treatment rather than waiting for symptomatic progression. And I agree with Dr. Nuka. I would be eager to try to use a venetoclax containing regimen in this setting, and would favor combining it with carfilzomib outside of a clinical trial, with just good education about that Bellini data and where the venetoclax development lies in the world of myeloma.
Great. So it sounds like, some of the take-home messages here are that, it's widely believed that pretty much all patients would benefit from maintenance therapy after an autologous stem cell transplant, even those who have, who don't have unfavorable disease features. And it appears that in this case, switching the ongoing maintenance therapy to a different one would be indicated. And there is some, I would say, enthusiasm in the field for venetoclax in the 11-14 translocation setting. And it seems like whether that would be in the context of a clinical trial in this case, would of course be preferred, or attempted off-label with carfilzomib would be a good direction to go.